This tracing will illustrate the new guidelines in terms of programming of the number of cycles required to fill the VF or the VT counter. This is the case of a patient with ischemic cardiomyopathy and multiple episodes of non-sustained VT before implantation and then implanted with a single lead ICD, or we could find in the memories of the device some episodes of non-sustained VT. You can see here the onset of the ventricular tachycardia. The first cycles are unbinned because there is a discordance between the current interval and the average values. After 1, 2, 3, 4, 5, 6 cycles classified T for VT, there is a diagnosis of non-sustained VT, since there is a spontaneous reduction of the arrhythmia. You can see here the markers VS2 corresponding to the discrimination channel. We will explain the specificity of the Secure Sense algorithm functioning in some other videos. So this kind of episode of tachycardia, the rate of the tachycardia corresponding perfectly with the multiple episodes of non-sustained VT that demonstrated this patient before the implantation. We could find in the memory of the device this kind of episode of non-sustained VT, so the same as the previous one, but with a little more cycles. So after 6 cycles non-sustained VT, but not enough cycles to fill the VT counter. We could see also this episode with the very same tachycardia, the exact same morphology with the same cycles, but now just a little longer, so the VT counter is filled. So therefore there is the first therapy of the VT zone that is delivered. This is a ramp with an acceleration of the arrhythmia and then a spontaneous reduction. Finally, we could find also this episode with once more the same ventricular tachycardia, a bit more cycles, so the VT counter is filled. A ramp is delivered as the first therapy of the VT zone, and then induction of a very fast and polymorphic ventricular arrhythmia detected in the VF zone. Diagnosis of VF, the charge of the capacitors, and then the shock is delivered with a return to sinus rhythm. This patient has underwent device implantation in the context of ischemic cardiomyopathy. We see multiple episodes of asymptomatic non-sustained VT from 4 to 20 cycles. He never had experienced an episode of sustained VT of syncope before the implantation. A few weeks after the implantation, he was hospitalized in the context of syncope with an electrical shock. Interrogating of the memories revealed many episodes of non-sustained VT, as well as few episodes treated by anti-tachycardia pacing and one single episode treated by shock. The analysis of the tracing demonstrated that it was the ramp that accelerated the stable clinical ventricular tachycardia that he had into a very fast and polymorphic and life-threatening ventricular fibrillation requiring the delivery of an electrical shock. So this ramp can be considered as an appropriate but avoidable therapy, since we could have waited for more cycles to fill the VT counter. It is very likely that there would have been a spontaneous reduction of the arrhythmia. So in the new guidelines now, it is clearly recommended to increase the number of cycles required to fill the VT or the VF counter, and this is what we have done in this patient. A second important point of this tracing is that the first therapy in the VT zone was a ramp, which is clearly surprising and against the latest guidelines, which favor the programming of burst versus ramp as first-line therapies in the VT zone. This very important paper has been recently published. It is a consensus about the programming of the defibrillators And one of the conclusions is that it is recommended to wait at least 6 to 12 seconds of arrhythmia before the filling of the VT or the VF counters. In this consensus, you can find different rules for programming, general rules for programming all the devices, but also specific guidelines for the devices of the different companies. And for the St. Jude Medical Abbott devices, it is recommended to wait at least 30 intervals in the VF zone to fill the VF counter, and the same 30 intervals in the VT2 counter.